Hi, this is Dr. Ali Kalia again with Stroke Prevention and Acute Ischemic Stroke 2019 Guideline Review. This is the last lecture, and mainly we're going to be discussing about hyperlipidemia treatment in acute ischemic stroke. So the most important thing is to, again, counsel the patients for lifestyle modification, dietary recommendation, class of recommendation 1, level of evidence A. Always measure a baseline LDL because you want to see the treatment progression once you have started them on statin. Always start them on statin. We're going to come to that in a little more detail for 4 to 12 weeks. Check the LDL and adjust the dosing every 3 to 6 months as need be, because lowering cholesterol, lowering LDL is very important as a risk factor reduction in these patients. Clinical atherosclerotic cardiovascular disease in patients or at the age of 75, those patients should have the goal of 50% reduction of LDL. So the idea is not just going to less than 70, the idea is 50% reduction of LDL in these patients. The level of evidence, as you can see, is A, and the class of recommendation is 1. Those patients who cannot tolerate high intensity statins, basically Lipitor of 80 or so, you should actually consider moderate intensity in those patients, and then the goal of reduction would be about 30 to 50% of LDL. In those patients that you're actually looking at that, the liver disorders, and there's always a big question, hey, is the liver going to get worse? Get the baseline liver function test, and then start the statin therapy, and then of course remeasure them in a more close fashion to see if there's actually any worsening or not. And generally speaking, it is safe to use them. The level of evidence is B, and the class of recommendation is 1. In those patients who are very high risk of statin issues, in those patients you can consider adding ezetimibe, which is basically another cholesterol lowering agent. As far as those patients who cannot tolerate at all statins, and I've seen a few patients in my clinical practice, and in those patients you need to use the injectable form of PCSK9 inhibitors. I don't want to use the brand name, but either way, you should consider using them. It's a once a month injectable. It's extremely costly. You have to have that discussion with the patient if they can afford that medication at all. But clearly, in those patients who cannot tolerate statin at all, disease-modifying medication like these are extremely important. This is a monoclonal antibody. So therefore, consider that in those patients. As you can see, the level of evidence is A, and the class of recommendation is 2A. Same thing in those patients you are actually having already on LDL, and it is reasonable to add ezetimibe in those patients if need be. The level of evidence is low. The class of recommendation is 2A. The choice of lipid lowering agents is extremely important, and it has to have a discussion with the patient and drug interactions, etc. So make sure that you're choosing the right medication for the right patient. Implementation, again, when you're talking about these medications, you actually have to have a discussion with the patient about the side effects, and then what are the other associated conditions that may or may not be influenced by lipid lowering agents, including diabetes. If the patient has associated side effects of statin, an alternative to statin can be considered, or a challenge can be considered with a different brand. It may still be a statin, but they may be able to tolerate a different generic or a brand form of statin therapy. So always keep that in mind. That can be at least tried with a second medication of a different sort of manufacturer, and then consider challenging the patient with that. As far as the timing is concerned, start it as soon as possible. Of course, it is part of the order sets and basically all stroke, inpatient stroke. And then you should start it as soon as possible. Special patients, especially women who are sexually active, and make sure that they understand that they have to use a very reliable form of contraception, because drug interactions can make birth control pills relatively unsafe in that situation. And if they got pregnant, stop it, because that can actually affect fetal birth defects. So make sure that the patient actually understands those risks. Lastly, In patients with advanced kidney disease, stage 3, 2, you should consider giving them LDL, but you can see that the class of recommendation is 2B. Those patients who are on dialysis, you should not give them LDL because that can actually worsen, especially those patients who have very advanced end-stage renal disease. They could have more hardening of the vessels with LDL. So therefore, it is important that you know that end-stage renal disease patients on dialysis should not be on statin lipid-lowering agents. Of course, treat patients with antihypertensive therapies. Make sure that they have their blood pressure under control and normotensive once they're out of the acute phase. Smoking cessation is a no-brainer, and everyone should get stroke education. Thank you so much for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.